and this is OBHealthy, and we are a group of physicians called Physicians Health Network. We're a group of Black physicians, and we're here because of several reasons. Number one is to improve the health of people of African descent. The second reason is to encourage young Black males and let them know that they can go into medicine. It's so important that we increase the number of Black males in medicine. For the population, we're far, far too few. Other things I'd like to say is our webinar is every second Saturday at 1 o'clock Eastern Time. Please let everyone know so that they can join us as well. Prior webinars can be viewed on OBHealthy's YouTube channel. All righty, remember to subscribe though, so we can continue to bring these webinars to you. The most important thing that I can say today is that don't change any aspect of your medical care until you consult your physician. Only your physician can truly understand your medical problems and treat you appropriately. Now I would like to, and let me not forget, thank you, OBHealthy. I'd like to thank that company for allowing us to use their platform so we can bring this webinar to you every month. Now I would like to introduce our physicians. Understand that physicians will be coming on and adding themselves as the program continues. But right now, let's introduce who's here. First, I'd like to start with Dr. Trevor Athley. Please introduce yourself. Understand Dr. Athley is our key person today. He's the special topic of cardiology. Dr. Athley, please.
Thank you. Thank you. Good afternoon, everyone. I'm Trevor Athley. I'm an interventional cardiologist. I'm based predominantly in the Essex County area at Newark Beth-Israel Medical Center. I've been here for a number of years. My practice involves general cardiology as well as non-invasive and interventional and invasive cardiology. But one of the great joys of my practice is, of course, in passing on the information to the youngsters. And I am a member of the faculty, the teaching faculty at Newark Beth-Israel Medical Center, training young cardiologists. Thank you.
Oh, thank you very much. And Dr. Jordan Garrison, please.
Good afternoon. My name is Jordan Garrison. I'm a board-certified general surgeon, bariatric surgeon, and vascular surgeon. Presently, I work for Metro Vein Centers of America, and I specialize in the treatment of varicose veins and diseases of venous disorders.
Thank you very much. Dr. Kareem Salam, please introduce yourself.
Good afternoon, everyone. My name is Dr. Kareem Salam. I'm a board-certified adult and child and adolescent psychiatrist. I work in and around Philadelphia. I do inpatient work, and I'm delighted to be here among this esteemed group, and thank you so much for having us. I'm also on the faculty of Drexel University College of Medicine, which is in Philadelphia.
And thank you, Dr. Salam, and Dr. Kendall Sprott.
Yeah, I'm Kendall Sprott. I'm a board-certified pediatrician and retired from practice, but remain on the faculty at Rutgers, New Jersey Medical School. I've done critical care pediatrics for about 15 years and specialized in general pediatrics and critical care.
Thank you, Dr. Sprott. I see that Dr. Patrick Anderson has joined us. Patrick, is your mic up? I don't think he hears us as of yet. Hold on. So when Dr. Anderson. Dr. Anderson? There, he's putting in his earphones. Dr. Anderson, one more time. Can you hear me?
I can now.
All righty, thank you. It's your turn to introduce yourself.
Okay. Welcome, everyone. Glad to be here. I'm Patrick Anderson. I'm a gynecologic oncologist, chief of service at Newark Beth-Israel Medical Center. Glad to be here.
All right, thank you. Thank you, Dr. Anderson. Well, our special topic today is cardiology, and it's one of those topics that we all, let me put it this way, it's important to us all, because if you live long enough, guess what? And I trust I have many years ahead of me, you will be seeing a cardiologist at some point. You know, I really think about the heart as that muscle, and Dr. Athley will be talking about this, that muscle that never stops. When you're born, it starts and it continues throughout your life and never takes a rest. So that's one of the interesting things about the heart. But Dr. Athley, you're the key today. So let's start off with the first question. What is a heart attack? Because I know that word brings fear to me. So I just want to know more about it, please.
Let me introduce the concept of a heart attack by telling you a little bit more broadly about cardiovascular diseases. As cardiologists, we're involved in cardiovascular diseases, and these involve heart attacks, disease of the heart directly, disease of the arteries and the veins, and of course, strokes. Now, a heart attack is a very special form of disease which damages the heart in a permanent fashion. When a heart attack occurs, it is in fact death of the heart muscle. Now, how does this occur? It is dependent upon blockage of vital arteries which supply blood to the heart. Let me explain a little of the anatomy of the heart. The heart is a muscle, and as you mentioned, it's a very powerful muscle, and you also quite correctly mentioned it doesn't stop. With rare instances, sometimes it stops and we have to restart it, but most times it continues throughout life unabated. So it's the hardest working muscle you've got. And while its job is to pump blood throughout the body, the heart itself does have requirements of blood and nutrients of its own. And these are met by small coronary arteries. In fact, I think I have my model of the heart here, if you can see this. This is a model of the heart. It doesn't look anything like this one, the Valentine heart, which people are familiar with. This is what the heart looks like, the size of a fist, okay? And the arteries I'm referring to are these small red streaks that you see here, which run on the surface of the heart muscle, then they burrow into the heart and supply the muscle with its important nutrients and oxygen. Now, these may become blocked. What are the circumstances under which these arteries become blocked? Well, there's a disease process called atherosclerosis, where fatty deposits occur, and these fatty deposits, oftentimes cholesterol, are deposited into the wall of these arteries, under the intima or the lining, into the wall of these arteries, and gradually block the arteries. So that alone does not cause a heart attack in most instances, but it predisposes to it. Because if there is a rupture of what we call plaques or of these areas of buildup of cholesterol, if that ruptures, it suddenly releases some noxious material into the bloodstream, which can then initiate blood clotting. Some of the components of the blood, the platelets, they clump together initially, and then they trigger off the entire spectrum of clotting, and the vessel becomes totally blocked. So you can imagine if an area of the heart muscle that is vitally beating at all times suddenly is deprived of blood, it suffers significant damage. And the damage, if it is permanent, is called a heart attack. Now, I say that because we can at times intervene, and I may tell you some of the methodologies by which we intervene, and stop the heart attack in its tracks. You see, the blood does not, when the blood stops, it does not cause an immediate heart attack and total death of the entire area. It causes heart damage, which goes on then to death of the muscle. And we feel that in human beings, for example, it's not the instantaneous thing that we've heard about, the sudden heart attack and you drop down. No, there may be other reasons why that occurs. But in the setting of a heart attack, the muscle dies, the total area of muscle that is supplied by that artery dies slowly over a number of hours, maybe up to 6 hours in human beings. So we have that opportunity, that window of opportunity to go in and save some of the heart muscle by aggressive intervention, which I could probably answer a little bit about if prompted or if required. So that is a heart attack. That is what happens. Death of the heart muscle, usually caused by rupture of those plaques and eventually total closure of the artery that supplies the muscle.
Yeah, Dr. Athley, you're talking, does anyone else have any questions?
Yeah, I just wanted to ask Dr. Athley about ischemia or angina. What is that, angina?
Okay, angina is a description of symptoms. Very important point you mentioned. And these are the symptoms which are sort of minor, like a minor form of heart attack, not an irreversible one, but one where the heart muscle is diminished in its blood supply. Now, the heart has certain requirements, and these are met by the blood flowing through the arteries. Now, as the arteries become narrowed, the amount of blood that goes to the heart muscle diminishes. So if under circumstances you increase your demand, for example, if you have blockages of the arteries, which are partial, not totally blocked like in a heart attack, but you quickly go up a flight of stairs, or if you have a sudden stress, or if you try to lift something too heavy, etc. Many circumstances under which you could increase the work done by the heart. Well, in a normal person, that work increase can be met by an increase in the blood supply. You have built-in reserve. When these arteries are blocked to more than 70% extent, then the reserve is severely limited, and one may then experience symptoms. But these may be transient. These may be symptoms less than half an hour where you feel chest pain. And the chest pain that is caused by diminished blood supply, but does not go on to form a full heart attack, may be called angina. So angina is that kind of description. You may come across many terms which are sometimes used as though they are the same, but they are not. They are not synonymous. Myocardial ischemia may be something you read about, and angina pectoris. These are terms which are thrown around, but imply the same sort of basic underlying disease, but different manifestations of them. The angina is actually just a description of the pain. And so that description of the pain may be met by other diseases than blocked arteries. You may have angina if you have blockage of valves. If for some reason the heart is diminished in its blood supply, or the heart muscle becomes too thick, hypertrophy that demands a larger amount of blood, even though the arteries are not blocked. So angina pectoris is a symptom complex, which describes a certain kind of pain. Now, let me tell you a little bit about how the angina feels then, with the understanding that this may go on to a full heart attack if the blood supply is diminished significantly enough and over a long enough period of time. Angina is a pain which is felt predominantly in the center of the chest. I know we think of the heart as a left-sided organ, etc., but it's left and central, predominantly in the center and somewhat to the left. But the location of the pains felt in a typical angina attack, that location is dead center. And it is not the needle stick, pinprick that people sometimes describe. It is in fact a squeezing, crushing, tightness, a heaviness, classically as though someone's sitting on the chest. That is the kind of discomfort that you feel when there is angina pectoris. It's very difficult for an individual patient to tell the difference between angina pectoris and an actual myocardial infarction. If in doubt, you certainly should seek advice as early as you can. But there are some patients who have angina pectoris and have had it described and documented for them, and have had it over a number of months or years, who become accustomed to it in what we call stable angina pectoris, where they know the sort of things that precipitate this pain and discomfort. For example, someone who's had some blockage of the arteries over years and knows that if I walk up the flight of stairs too quickly, I may get chest pain, and that chest pain may be angina pectoris. And I reverse it by stopping what I'm doing, relaxing a bit, or taking medication to ease and alleviate the pain. So angina pectoris is reversible. Myocardial infarction is not reversible, but we can stop it from being complete in its destruction of the heart muscle. Okay.
So Trevor, if someone has angina, what might the cardiologist do to reverse it or prevent the heart attack from occurring?
Yeah, well, I think the first thing is to diagnose it properly, because I will admit that there are many mimics. There are many other causes of pain which appear similar to angina pectoris. So the most important is to diagnose it. And the diagnosis requires taking a fairly detailed history from the patient, at which time you ask them about the symptoms, not only about the symptoms and about the factors which precipitate those symptoms, but you ask for a lot of other things which can give you a clue as to the underlying potential for them to have blocked arteries. For example, family history, presence of other risk factors, which we may discuss. Multiplicity of those risk factors could give rise to blocked arteries. And you ask them then the details about the pain. Because I will say that most patients who come to my office with complaints of chest pain turn out on careful questioning and testing not to have angina pectoris secondary to blocked arteries. So the test that we do, if we suspect that the patient's arteries are blocked, then is to try to define them either indirectly or directly. The most direct and the ultimate test is the one that we do not jump to initially, but ultimately get there after we've gone through other tests. So the ultimate test is cardiac catheterization, coronary angiography, and I will explain what those terms mean. what we do is pass a tube through the tiny arteries in the groin area or the arm backwards toward the heart. The arteries emanate from the heart, and so they lead backwards. We pass this tube there and inject dye, an iodine-based dye, through these tubes into the arteries of the heart. We can then, under X-ray vision, we can observe how well the dye is flowing through those arteries. We can define areas of blockage. We can define where they're occurring, how severe they are, and how many there are. And if indeed we do see significant enough areas of blockage, then we go on to specialized treatment, which again, we'll discuss in a moment. But testing, the ultimate test is called coronary angiography or cardiac catheterization to define the areas of blockage. Before that, however, since that is an invasive test, by that I mean we put tubes into the body, we do not initially go for invasive tests, we do non-invasive tests. A simple electrocardiogram. So a patient presents to the office, we examine the patient, we hear the story, and this pain sounds as though it is angina pectoris. Then we do electrocardiograms, and electrocardiograms may or may not give the answer. Electrocardiograms may show some non-specific findings or give us very specific ideas as to the presence of blocked arteries. If the simple electrocardiograms do not yield the full answer, we may go on to stress tests and look at stress electrocardiograms. What's a stress test? A stress test is done with the concept that patients who have blocked arteries do not have sudden total blockage initially, but the blockage develops over many years, sometimes over decades, the blockage may develop. And only after it reaches a certain level does it cause significant pains. But if there are blockages there that are achieving significance or near significance, and you make the heart work harder, you put the patient on a treadmill and get them exercising on a treadmill. If you make the heart work harder, then there's an increased demand for blood. And in the event that there is or are blockages, then that increased demand cannot be met. So what happens? The patient may feel pain at the time of the stress test or may exhibit certain changes on the electrocardiogram. So we're able to interpret the changes on the simple electrocardiogram rest or with exercise in these patients. We interpret these changes as indicating a need for more blood and insufficiency of the blood supply. Now, there's an added sophistication to this test where we not only look at the electrocardiogram, but we look at other parameters that tell us that the heart is not getting enough blood. And many of our members of the audience may have heard of nuclear stress tests, often called thallium stress tests. These are performed with the injection of a radionuclide, which perfuses or goes to the heart through these arteries. And we can make the assumption that if we see impairments, that is, inadequacy of this nuclear material showing up on pictures, nuclear pictures, if we see inadequacy in certain areas, then my goodness, it must imply that those areas are not getting enough blood. If that happens during the course of the exercise, but after or before exercise, we see that there's no impairment, that the blood is flowing well, then we can call that myocardial ischemia, and we can assume that the pain that the patient was having was angina pectoris secondary to partial blockage of these arteries. Now, it may be important to define these partial blockages so that we can then go on to treat them more specifically if required. So that would be another major test. Another test that we sometimes perform is an echocardiogram. We perform an echocardiogram for a variety of reasons. In the setting of a fresh heart attack or angina pectoris, we may see changes in the strength and contraction, the pattern of the contraction of the heart, which may give us a clue that some area or areas of the heart muscle are not functioning well because of blood insufficiency. You can stress a patient, put the patient on exercise or give certain chemicals to stress the patient's heart and look to see how well the heart is contracting. And in the event that during the stress, you see areas of the heart muscle which are become impaired in terms of their contraction, in terms of their pattern of function, but these recover or were not impaired before, then one may again assume that is because we've affected the supply-demand ratio of the heart. We've increased the demand, but we cannot increase the supply, and the heart shows with the abnormalities of function that we mentioned. So yes, it is very important to try to determine the underlying basis for the patient's chest pain, and angina pectoris and acute myocardial infarction are two of the more important reasons for significant chest pain.
Doctor,
Hold on. Let's go with Dr. Salam, and then we're going to go with Dr. Patrick Anderson.
Sure, thank you. Dr. Athley, I have two questions.
Sure.
Number one, if a person is alone and they're experiencing chest pain and they think they might be having a heart attack, are there things they can do while they are alone and still conscious? That's my first question. And my second question is, are there specific elements of the family history that you're looking for that suggests that someone may be at heightened risk of underlying cardiac disease?
Excellent questions. If a patient is alone, one may look at it in terms of the new pain or pain that the one is accustomed to. If an individual has already had a heart attack or has had these pains diagnosed as blockage of the coronary arteries and recognizes the fact that he is at high risk for a heart attack, he should immediately chew an aspirin. You could take a 81 milligram aspirin, chew that immediately and seek help through an emergency room, call for emergency help. Now, I don't want to panic the general audience by having them come to the emergency room each and every single time, because pains can occur for a variety of reasons, as I mentioned. But if one has the impression or is convinced that there is a heart attack in progress, then those would be the two things that I would recommend to be performed immediately. Seek help and chew an aspirin. The reason we chew it is because it may be absorbed sublingually, that is under the tongue. It may be absorbed much more readily than waiting for it to be swallowed and then absorbed through the gut. So these are two things that we should do. The second question that you asked was in regard to the family history. Yes, the family history is a very important one of the risk factors. We look at so-called risk factors. That is a number of characteristics that we look for. There may be diseases or there may be other factors which can increase the patient's chances of having heart attacks, having coronary artery blockages, having angina pectoris, these sort of things. So what we look at is whether or not close family members, mother, father, brother, sister, siblings, close family members, not distant cousins, whether close family members have had heart attacks or documented heart disease of coronary artery disease at an early age. If your relative had a heart attack at age 95, then it does not constitute a significant risk for you. If, however, your mother or father had early heart attacks, premature heart attacks, then you are clearly at significant risk, at increased risk for heart attacks. Now, what do we mean by premature? Males 45 or less, females 55 or less. Females tend to be affected at a later age than males. If these occur, then you recognize that you are at increased risk. It does not mean that you have to take immediate treatment. What it means is that you must look for other risks, so that the accumulation of multiple risks increases your total risk significantly if there are more than 3, for example. So what it then will be, the onus will be on you to control or correct those other risks, which you can. And again, we'll talk about the other risks and which are modifiable and which are not. So having a close family member having a premature documentation of heart disease at an early age is clearly a risk for you, but is one of those risks that you cannot affect. You cannot affect who your parents and your siblings are. Therefore, the onus is on you to affect or control those factors, however, which you can control.
Excellent. Dr. Athley and Patrick, I want to get to you. You mentioned other risks. Just real quick, what are the other risks? Hypertension, what are the other risks you're talking about?
Well, we categorize them into 2 groups. One, the modifiable and the non-modifiable. I mean, you cannot modify your age. As you get older, you're more predisposed to having heart attacks. I said already you can't modify or choose who your parents, your relatives are. Unfortunately, you can't. So if they have had heart attacks at an early age, then you're also more susceptible. Sex. Males are affected more than females at an earlier age. And even though females after the menopause tend to come closer to males, they don't quite catch up in terms of the occurrence of heart attacks. So those are 3 of the non-modifiable risk factors that you can't really change. We find some racial factors are also important, that we are now understanding that in fact, African Americans are at higher risk for heart attacks and heart disease than others, than white European populations. And that is quite a reverse from the days when in the ancient days when Dr. Sprott and I were in training, where we may have thought in those days that, sorry to pick on you, Kenny, but you're already retired. So that tells us something, right?
We are old.
Huh? That's maturity, not age. When we were training, we didn't think that blacks had heart attacks or heart disease as frequently as we saw in the whites at that time. So these are some of the factors we can't really change. Now, there are modifiable risk factors, and Omar, you alluded to hypertension, and clearly that is one of the major risk factors which we can affect. You know that high blood pressure is seen quite frequently in African Americans. So high blood pressure certainly is one of those that can predispose us to having heart attacks. Again, I don't want anyone to panic because we look at the multiplicity of risk factors rather than a single risk factor, and try to modify your entire lifestyle and modify as many of the risk factors as you can. But hypertension is one of those that is modifiable. Control of the hypertension will diminish your potential for heart attacks and heart failure and strokes and even kidney disease. Diabetes. Again, there has been a recent increase in diabetes in African American populations, and diabetes is one of those diseases which, by controlling the disease, we do have an impact on the risk for heart attacks. We do not totally remove it as a risk factor. Once you're diabetic, you're diabetic. But controlling the diabetes does have an important beneficial effect on heart function, heart disease, heart attacks, congestive heart failure, etc. Cholesterol, as you're all aware, cholesterol is very much a topic. We look at two kinds of cholesterol. We not only look at the total cholesterol, which used to be the standard, but we look at the breakdown of these cholesterols into LDL or low density lipoprotein cholesterols and HDLs, high density lipoprotein, with the understanding that the cholesterol is carried in the bloodstream by the LDL in and deposited in the coronary vessels and other arteries of the heart. And the HDL seems to be pulling it away from the blood vessels and takes it towards the liver and other areas where it can be excreted. So the HDL is a good guy. HDL is the one that helps to remove and diminish the bad effects of the LDL. We have certain numbers, certain standards that we like the general population to know. We try to make it simple. The total cholesterol should be less than 200. The LDL, you should always know your cholesterol. I remember years ago when I was heavily involved with as president of the American Heart Association in New Jersey, we tried to mount a campaign and said, well, people know their blood pressures now. Do they know what the cholesterol is? Do we all of us on the panel know our cholesterols? Your LDL cholesterol should be less than 100 if you've not had significant heart disease. If you have had significant heart disease, open heart surgery, or heart attacks, then we aim for 70. Your LDL should be less than 70. Your HDL varies in males and females, a little bit higher in the females. The HDL should be protective enough to counter the effects of the LDL if your LDL is elevated. So you want to know your total cholesterol and especially your LDL cholesterol. You also should know your HDL cholesterol.
Excellent.
Number one, the risk factor.
Patrick. Oh, all right, Patrick, it's your turn.
Yes. So Dr. Athley.
Well, I'll go on to ask some questions and maybe we can answer the others later on. There are a few other modifiable ones which we really want to hammer on you to control. But go right ahead, Patrick, and I'll
right.
so
answer your question. Conceptually, there are two sets of blood that goes into the heart, one of which you described very well, which supply blood support to the heart muscle itself. And the other one is that which the heart is in place to do, which is to pump blood to the rest of the body. Can you elaborate how abnormalities of the vascular system, the system for which the heart does its work, affects the function of the heart itself?
Abnormalities of the vascular, you mean outside of the heart?
Outside of the heart, yes.
Yeah. Yes, well, there are some other diseases which can, of course, increase the heart work. For example, I believe I want to look at high blood pressure as one of those. High blood pressure, in fact, may be associated with increased resistance, of the arteries and the small branches of the arteries, and can increase the work of the heart. So that is one of the arterial diseases which can. One can have dissecting aneurysms of the aorta, outpouchings of the arteries outside of the heart, the large arteries called the aorta, outpouchings and even tearing of that. may also cause heart problems and significant symptoms, and may in fact rupture and cause death. The venous system, the veins bring blood back towards the heart, and blockage of the veins with thrombus or clots can be associated with breaking off of these clots and their passage into the arteries, into the heart, and into the arteries to the lung, causing pulmonary embolism or blockage of those arteries with, again, severe consequences in terms of symptoms and even life or death. So blood vessels, arteries, and veins outside of the heart may indeed affect the heart in its function and may cause significant suffering and even death. And maybe we can chat with Dr. Garrison a bit about some of the vascular diseases that he may be concerned about. Jordan?
Okay, once again, thank you, Trevor. I think that was a pretty comprehensive review of all the stuff that goes on with the heart. Quick question. How do you mend a broken heart? But anyway,
I thought you were going to start singing.
I will answer that by the way.
I'll pass on that one.
No, you can't. No, you
That's
can't.
on you,
I'm going to involve you with that one. I am going to involve you in a rather serious aspect of it.
Okay, that.
But I think the serious aspect of it does exemplify the integrative nature of the whole cardiovascular system from an emotional perspective, where emotion gets involved. That can affect the blood pressure, even if it's transient. And that in effect can affect the heart in several ways, right? Strokes, even heart attack to some extent in patients who have marginal reserve. Mm-hmm. So, you know, it does highlights how integrated the cardiovascular system is, both from a physical perspective and from a psychological perspective.
So to get into the diseases that we're talking about, there's two systems that we really need to talk about. One is the arterial system. And the arterial system is the delivery system. It delivers, as Dr. Athley alluded to, it delivers oxygen and nutrients to the tissues. And in the periphery, or in the legs or extremities, we talk about the delivery of oxygen to the toes for the muscle function of the legs. There's a condition called claudication, which is very similar to what is called a heart attack, in that there's an activity or a stressor and there's delivery. If that delivery is impeded in any way, shape, or form, it will cause pain, most likely in the calves, most particularly in the calves. Then when the stressor is relieved, such as if you're walking or running, and that stressor is relieved, the pain goes away. That is sort of like angina of the legs. This condition can be treated by changing your lifestyle and increasing your exercise. There is no real surgical treatment for what is called typical claudication. Now, if you get other diseases or other types of pain, such as rest pain, where you elevate your legs like you're laying in the bed and you get pain typically in your big toe, that is called rest pain. And the patient says, I drop my toe down and I rub it a little bit. And what happens is you increase the amount of blood flow to that area, and it goes away. That is something that is an indication that some type of intervention needs to be had. Or if you get discoloration of your toes or your limbs, from either blockage of those arteries, from an irregular heartbeat shooting a clot down, or diabetes, which would give rise to the arteriosclerosis that Dr. Athley was alluding to, those types of things require surgical intervention. On the other hand, the venous system gives rise to return of blood to the heart. Now, this return is in a sequential fashion. It should only be in one-way system. If you have a condition called a deep vein thrombosis, where the veins in the center of the leg form a clot. If that clot is above the knee, typically they will break off. They will go into the heart on the right side of the heart. The right side of the heart will pump it into the lungs, and you'll get something called a pulmonary embolism. This is a life-threatening condition, and it needs to have immediate intervention. The other thing that happens in the venous system is you get insufficiency, where the blood is not returning to the heart in an efficient manner. The Treatment for this is to close down the inefficient veins so that the blood only goes through the veins. This will not really have a major influence on the function of the heart, but it will make the blood return more efficient, and diseases that occur in the legs will abate or improve. So those are the two systems that are closely related to the heart, the veins upon delivery and the veins for return.
I have one question, Dr. Garrison. Varicosities, and I know this is frequent as we get older. Are they a concern for that clot that's coming up, or that pulmonary embolus, or that break off of clot? Should we be concerned if we have varicosities or varicose veins?
Actually, varicose veins are the exact opposite of what is called the DVT. Again, DVT is a clot. It's caused by trauma to the veins. It's caused by dehydration. It's caused by poor flow in the system, and that will cause clotting. Diseases such as cancer, Dr. Anderson can talk about the reason why you get clotting with cancer. But no, a DVT is the exact opposite of varicosities. Varicosities tend to be a hereditary condition in which the veins have dilated. Therefore, the valves which cause the blood to go up only have now become incompetent. So the blood flow is up and down. So it's the exact opposite of a clot. It's where you have too much blood flow, but the blood flow is going in the opposite direction.
Excellent. Excellent.
You know, just a couple of questions. One, I know I had a friend who Trevor knows well that ended up having really an arrhythmia that caused him to arrest. And his concern was that he had had some tests done on his carotid arteries that showed that there were some issues with blood flow to his brain. And the question is, if you have those kinds of concerns, is there a correlation between blockage of carotid arteries, or the blood arteries going to the brain, and the coronary arteries?
Yes, there is. But I'll also let Jordan answer that. But we're discussing.
I'm sorry, can we define an arrhythmia?
Yeah, I was going to ask that. Arrhythmia
I mentioned that
and
too.
an arrest.
Okay, there are several questions at once, but let me just talk about the correlation of blockage in arteries. What we're discussing is the process called atherosclerosis, the process by which cholesterol is deposited in the arteries. And this may be deposited in several arterial beds throughout the body. And in fact, the appearance of blockage in any one arterial bed is a clue that we should look more closely at the other arterial beds. So the areas in which we see disease manifested are, of course, you mentioned the heart, where the blockage can occur in the small arteries to the heart, but the peripheral arteries to lower extremities, as mentioned by Jordan, for example. And now we're discussing the carotids, the neck arteries. This is all part of the same process. So a clue to blockage in any one area would be to look to see if there are other areas in which blockages have been defined. Do you want to answer any more of that, Garrison? Jordan, otherwise I want to mention the arrhythmia aspect.
There was a question in the chat about TIAs, and I think Kendall was alluding to TIAs, but to the next level, which is a stroke. Basically, a TIA is transient ischemic attack, and it's a mini stroke that lasts less than 24 hours. What happens, as Dr. Athley has said, is that you get plaque deposition within the carotid arteries. The carotid arteries supply blood flow to the brain. When you get this plaque deposition, you can get breakage of these plaques, these little fibroplaques, which go up into the small arteries in the brain. And this can cause a blockage. And therefore, with blockage, you have decreased oxygen getting to the brain. The brain is the most sensitive organ to lack of oxygen in the body. And so you're going to have changes. You're going to have changes, typically something called amaurosis fugax, which is described as if a shade was coming down over your eye. And that's the artery that goes to the eye, and that's what that is called. The second thing is you can have slurring of speech, you can have deviation of the tongue, and you can have decreased mentation. That is when you have a plaque breaking off from the carotid artery. You can also have, as we talked about, arrhythmias. You can have an irregular arrhythmia in the heart, which will form a clot. Atrial fibrillation is known for this, and that small clot can go up to the brain and cause the same problem. The treatment of these, the diagnosis is first made with ultrasound, and then if ultrasound shows a certain significant occlusion or obstruction in the artery, think it's greater than 50% of the cross-sectional diameter of the artery, then you would go to an angiogram. And once you have an angiogram, that would determine whether or not you need to have surgery. If there's greater than 50% cross-sectional obstruction of the artery, that is the indication for surgery. If it is less for that, the studies have shown that there's no difference in doing surgery on those patients as opposed to giving that patient a single aspirin once a day. And they even say you don't need a whole aspirin. All you need to do is just lick the aspirin and it'll give you the protective effect. Because these clots that occur are platelet clots, and the aspirin is a platelet poison. So therefore, you need a small dose of aspirin to poison the platelets so they don't clot. Okay?
Now for Jordan and Dr. Athley, I know that some of these plaques have calcium in them, and I know that there's some CT scans that can be done that determine a calcium index to look for calcium deposits in coronary arteries and maybe in the carotids. What do you think of the CT scan to looking for calcium in plaques?
I can answer that very briefly. The calcium is an indication. The calcium score is an indication of how heavily or how densely the calcium is deposited in the vessel. It does give calcium scores over a certain level do indicate a high likelihood of blockage of the arteries, the coronary arteries. But you must bear in mind where the calcium is deposited. And the calcium deposited in the wall of the vessel does not necessarily block the lumen or the inner portion of it, so that passage of blood may still be adequate even in the presence of high calcium scores. So sometimes we see patients we bring to the cardiac catheterization laboratory who have high calcium scores, suggesting very strongly that there's significant enough deposit of calcium in the walls of the vessels to partially block them. And in many of these patients, unless there are other indicators, we may find that the degree of blockage does not impair the flow through the vessel. So they do tell us two different things, but we can sort of surmise that if there's enough calcium and if the scores are high enough, that perhaps it does intrude upon the lumen or the inner portion of the vessel through which the blood flows. You see, the blood flow is only concerned about blockage inside the pipe. It is not concerned about the wall of the pipe being rusted or partially blocked or etc. or disease. It is concerned with what's going on inside the pipe. That is what impairs the flow of blood. Or
Trevor, what about the reverse? Suppose you have a low calcium index. Does that mean that you don't? Suppose that you have a low calcium index. Does that mean that you don't have issues of blockage inside?
Not necessarily, but it's a good screening tool. It is a good screening tool, so that a negative test, yes, does give you some good information that you're unlikely to have severe disease.
All righty. We got some feedback there just for a minute, so hopefully it's solved. I'm not sure which one of us came through with the feedback. Okay. Who was that, Jordan?
Yeah, I would like to ask Dr. Athley, to maybe go in on the difference between coronary artery angioplasty as opposed to coronary artery bypass, and maybe what the indications for one versus the other is.
Okay, fair enough. When the coronary arteries become blocked, our first line of approach may indeed be medication. Unless it is an acutely forming, unless we catch a clot forming at the time, which might occur, say, in a heart attack, we generally do not intrude upon the blockage unless it is acutely formed by medication. We have to rely on mechanical means of trying to get rid of the blockage. Okay? So in the setting of an acute heart attack, where a blockage is occurring with soft plaque, as we say, with blood clot, we can have several methods of approach. One of which is to dissolve it away in or out of the cath lab. We can dissolve it away with medications which are called clot busters. We use that far less frequently. These are medications powerful enough to dissolve away the clot. What we instead do when there's blockage of the artery as occurs in acute myocardial infarction and acute heart attack, if there is significant blockage there, we can go in and we can remove it mechanically, or we can put stents in, and we'll tell you about stents. I think someone asked about stents as well, versus open heart surgery. But in the setting of angina pectoris, we're seldom able to remove a clot. There's seldom a significant clot. The more likely is progressive blockage, hardening of the arteries, impinging upon the passage of blood through the arteries. And in those circumstances, medication will not remove that blockage, but we may require mechanical solutions. Now, what are the mechanical solutions that we have at our fingertips? So first of all, we have to define the severity of the blockage. And in blockages which impair the blood flow, which are involved with more than 70% of the luminal diameter of that artery, then they're considered significant enough. We sometimes, even in the cardiac catheterization laboratory, pass tiny tubes into these arteries, and we can measure not only blood flow, but we can measure the effect of the blockage to see whether it is truly causing a functional impairment. If we are convinced, then we have mechanical means to fix these. Fixing them from the inside, a method called coronary angioplasty or stenting may be performed. What we do, we have a catheter already placed in the artery of the heart, in the small coronary artery, and through this we pass an even smaller catheter through this over a wire guide and position it into the area of blockage that we consider causing a problem. You see, there may be many areas of blockages in the heart and in various arteries, but we try to identify ones which have reached a level of severity such as to require involvement mechanically. So we pass this tiny tube with a balloon on it, blow the balloon up, and place in position a stent, which is a small metallic, sometimes a covered metallic device, something like the spring of a ballpoint. If you remember the old ballpoint pens we had, the little spring there in them. Well, it's something like that, much smaller, of course, much smaller. So we have to delicately pass these through the area of blockage, inflate the balloon, and deploy the stent to mechanically support, to act as a support for the artery, keeping the artery open. Whereas you may have had an artery which was blocked about 90%, when you finish your procedure, and with the stent forming a scaffold, you're now left with an artery which is open to from 90% blockage to 0% in most times, allowing good, clear passage of blood through it. You will have the wall of the architecture of the vessel affected, of course. You put a permanent device in there, but you've opened the lumen, you have the opening such that, as I said, all the blood is concerned about is how big is the passage for it to pass through. So it can do that. Now, we're not always able to do that. That is preferable where they're focal or localized, limited areas of blockage of a specific severity and documented to be causing a problem. There we go ahead and do that stenting. There are times when the location of the blockage, the multiplicity of the blockages, or other specific characteristics that we can pick up when we take these pictures suggest to us that the likelihood of success, both in the initial performance of the procedure of stenting and in the long-term likelihood of keeping them open, that we may decide, no, it is better at this time to do open heart surgery, the more traditional form. And the open heart surgery in these instances is to create bypasses. Now, what exactly is a bypass? If you were traveling down a road and you knew that there was a traffic block a little further down that road, you might deviate to another road to the left or the right, run parallel to where the road that has the blockage is running, and then rejoin the road a little further on beyond the area of the blockage. Well, this is precisely what the surgeon does. He takes a tube, and this is usually a vein from one of the lower extremities, one of the legs. He may take a piece of the vein from there, your own vein, attach one part of it to the aorta, a large artery that comes from the heart, and then bypass or put it beyond where the blockage has been defined to be in your artery on the heart itself, the coronary artery, and put this a little beyond that area. So now what we're doing is circumventing that blockage. We're not removing it. It merely carries blood beyond where the blockage occurred in the coronary artery. And this blood therefore can reach the further, more distant parts of the heart muscle, which may have been previously deprived, partially or totally, of blood supply because of the blockage. So the open heart surgery with the bypass surgery tends to be done in situations where we cannot easily perform the stenting. It is preferable nowadays, and speaking as an interventional cardiologist doing stenting myself, we prefer to fix these ourselves if we can. And in the event that we meet the specific abnormalities that render it much more difficult or not likely to be successful, then we call upon the surgeon and let the surgeon go ahead and do bypass surgery.
There
were a number of questions if you wanted to go on to any of the others.
Yeah. Hold it just for a minute. We have someone that has their phone on. There's a background echo with one of us. Can we check that? If you have a phone on, please, or if you have two devices on, can you turn the volume off of one of the devices so that we won't get the background echo? Thank you. Dr. Athley, there are quite a few questions are coming through. There's one about the placement of a watchman. Can you explain that? Something about atrial fibrillation, or please discuss the placement of watchman.
Okay. This is a device that is placed to help us treat atrial fibrillation. What is atrial fibrillation? I suppose I should expand a little more generously on the whole concept of arrhythmias of the heart. I think someone else had also asked that question verbally before. Arrhythmias are irregular heartbeats, and these may be manifest to the patient in a variety of ways. But the commonest, I suppose, is the patient's awareness of a little skip beat or a thumping in the chest or a missed beat, as it may be called. We can document by virtue of electrocardiograms which may be performed at that time, or electrocardiograms which may be performed over a prolonged period of time, special monitors that we allow the patients to wear over a period of either 24 hours or as long as up to 2 weeks, some of these monitors. But we define what the heart has been doing electrically. As you may or may not recall, the heart is a very powerful pump, but it requires the stimulus electrically to be passed from the upper chambers to the lower chambers to synchronize and smoothen out the process of proper and orderly contraction. Well, these arrhythmias or irregularities may disturb the regular contraction of the heartbeat, and the patients may be aware of them. They may even be aware of more significant symptoms related to arrhythmias. They may be aware of fainting, dizziness, etc., the feeling of breaking out in a cold sweat, feeling of wanting to faint. All of these, or many of these, may be related to arrhythmias. Now, what then are the arrhythmias that are common? Certainly one can get isolated or single beats which beat a little out of turn. One part of the heart beating a little out of turn, oftentimes in the ventricles or the powerful pumping chambers, and patients are often aware of these. Hopefully, if they're just single or few, they may not cause significant problems. If, however, these are sustained or continued, they may then cause problems, especially if there's underlying heart disease. So the commonest underlying arrhythmia in older patients, the commonest that we see nowadays, sustained over a period of time, is called atrial fibrillation. And this is where those thin wall chambers, the atria, beat erratically, like a bag of worms, beating erratically out of turn, sometimes rapidly, and cause the electrical impulses to go down to the lower chambers, the powerful pumping chambers, in an erratic or irregular method. So atrial fibrillation originates from the atria or the thin wall chambers and can cause a variety of problems. There are two problems that may be caused, other than just the symptoms of feeling them. One is concerned about the rapid heart rate. If there is indeed a very rapid heart rate affecting the ability of the heart muscle to pump blood efficiently. So the tissues in the body may become aware of a paucity of blood because of inadequate flow of blood from the chambers, the big powerful pumping chambers, out to the rest of the body. So inadequacies may occur in that regard, especially to the brain. The other concern that we have, and perhaps an even more striking one, is the potential for those small chambers to be the site or nidus of blood clots. Now you see, if the heart is pumping effectively and smoothly and functioning well, the blood does not stagnate in a part of the heart. It flows properly from the right side to the lungs and then from the left side up to the rest of the body. If, however, atrial fibrillation is occurring, a portion of these small chambers, the atria, may not empty properly. And that is called the atrial appendage, especially on the left side we're concerned about. That's a small outpouching of that chamber in which the blood may just stay and stagnate. Now, what can happen if you have the blood stagnating? You may have blood clots forming. And the worst thing that can happen, they're not going to cause much of a problem if they remain in place. The concern we have is if these blood clots move and go into the bloodstream, and of course, where can they go? To the brain. That would be the worst consideration. So in essence, we may have strokes caused by blood clots moving in the setting of atrial fibrillation, the most significant sustained arrhythmia. We may have these blood clots moving to the brain and causing strokes. So how do we prevent this? Well, the commonest way, of course, has been if we accept the presence of atrial fibrillation, we have to also accept the potential for clot formation and give patients blood thinners to prevent or to limit the formation of these clots. That would be one way of doing it, using anticoagulation or blood thinners. And we've all heard of warfarin or Coumadin and some of the other newer ones. Well, the Watchman, and long-windedly getting back to the question of the Watchman is a mechanical solution for this. The concept is that it is in the appendage, those small outpouchings from the atria, that clots form. And the clots have to leave that area, migrate through the left side of the heart, if one is concerned about as we're talking about strokes, migrate into the ventricles and then be shut off from the ventricles to the areas of the heart, of the body, where they can cause significant problems. So we trap them in there. The Watchman, therefore, is a mechanical device which is implanted without full open heart surgery. It's implanted through passage percutaneously, that's through the skin, up into the heart. This device may be placed into the atrium, blocking or occluding the exit from the atrial appendage, so that clots that form in there cannot escape or run to other parts of the body. So essentially, it's a mechanical solution to block the travel of these dangerous clots to the brain and other vital areas.
Excellent.
Dr. Athley, could you speak to the difference in presentation of cardiovascular disease in men versus women?
Yeah. And Dr. Salam, after he speaks, I want you I would like for you to try to just bring us together as far as mind, body, and soul. We've been speaking about the physical, but I need to know about the mental and the spiritual aspect of this, because I think the body is more than just the physical aspect. But Dr. Athley, go ahead, please.
All right. There are various presentations of the heart which may be affected by the sex of the individual. Certainly, I did allude to or mention earlier that heart attacks, blockage of the arteries of the heart, these tend to occur at a younger age in males, and females are more protected up to the age of the menopause, and the disease process of heart attacks, etc., these occur at a later stage in females when compared to males. The progress of these diseases and the consequences are also slightly different. That females seem to have a higher potential for mortality. They do worse at surgery, so they have a much greater impact on females' heart attacks than on males. But this may be for a variety of reasons, one of which may be the inadequacy of documentation or diagnosis. You see, the commonest symptoms that we rely upon to tell us that heart attacks are happening, or angina pectoris, as I've been asked about, the commonest symptom really is chest pain. And typical chest pain has characteristics which are much easier to recognize. Well, females tend to have a higher proportion of these atypical symptoms, where they do not have the typical classical center of the chest pain, etc. But they may present with some of the other ancillary findings. The pain may be in the arms, the neck, the shoulders, occurring a little more frequently in those areas than would occur in males. And the other ancillary factors, such as profuse sweating, what we call diaphoresis, shortness of breath unexplained, a feeling of faintness, these also may be considered manifestations of heart attacks. Now, again, I don't want to suggest that there are always suggestions of heart attacks, but there are some of the ways which heart attacks may occur. And we know that up to 20% of heart attacks may occur silently. That is, without the usual fanfare and the usual pain that can be recognized easily, but may occur either with no symptoms at all or with those atypical, unusual symptoms. Well, females of all ages that are susceptible, and the elderly especially, may present with more of these atypical symptoms. So those are some of the ways in which females may differ a little bit in their presentation in coronary artery disease.
Yeah, thank you.
Omar, when Dr. Salam is finished, I have a question I'd like to ask.
Surely.
Yeah, and Omar, before Dr. Salam kind of bring it all together, I just want to ask Dr. Athley a couple questions. One,
I know this is a great topic. I know this is a great topic. Hang in there, guys. We're going to get to everyone. We're going to get to everyone.
Yeah,
Patrick, go ahead. Go ahead.
The broken heart syndrome, but that's where Dr. Salam comes in. I'm more of a physical type. Can you elaborate on some of the consequences of a heart attack, such as what happens to the heart when you have a heart attack and ultimately the muscle kind of becomes weak and doesn't pump rhythmically? Good point.
Yes, it's important to recognize there's so many different things we can discuss that are amazing about the heart, but it is important to recognize that the heart attack doesn't just come and go. You have a bit of heart muscle that dies and that's the end of the story. As you quite rightly suggest, that there are consequences. Now, in order to pump adequately and to push the blood properly and do the tremendous amount of work which the heart has to do, we require all aspects of the heart to function properly. And if you had a heart attack and it left a certain portion of the heart unable to function, that is scarred, dead area of the muscle, which may never regrow, then the rest of the muscle has got to try to make up for that deficit, and it may not successfully do so. So the heart may weaken as a pump overall, and this can be manifested as congestive heart failure or inability of the heart to perform its total function. So heart failure may occur as a consequence of the extent of damage that occurs to the heart. In fact, if this all occurs at one time, 40% of the heart being damaged could put one into shock if that were to happen over a rapid period of time. Gradual worsening of the heart muscle occurs over a period of time, even after the heart attack. And the areas of the heart that were compensating may no longer be able to compensate adequately and may potentially worsen the overall function of the heart. So congestive heart failure, failure to function properly as a pump, is a major consequence of heart attacks. Of course, one of the consequences that I did not mention initially was cardiac arrest or significant arrhythmias that may occur also at the time of the heart attack. These may occur very often, in fact, in patients who die outside of the hospital. The sudden death that occurs with patients outside of the hospital associated with heart attacks is often related to lethal arrhythmias, lethal irregularities, not the atrial fibrillation that I mentioned, which is much less severe in terms of the immediacy, but lethal arrhythmias may be where the lower chambers of the heart, the ventricles, beat erratically in what is called ventricular tachycardia or ventricular fibrillation. And there, this disorganized beating of the heart is so severe that patients, of course, may faint, may pass out, may become unconscious, and in fact, may be unable to sustain life because of the impairment of blood supply to the vital organs. So there are arrhythmias and there's congestive heart failure, and these are two of the major consequences of heart attacks. Now, I want to hear what Dr. Salam has to say because I've got a question for it too, in that regard.
All righty. Dr. Salam, I promised Dr. Salam he'd be next. Go ahead.
Absolutely. So, we have a tendency in medicine to erect these artificial walls between the mind and the body, but these things are connected and the connection is bidirectional. So problems with the mind could affect the body, and the converse, problems with the body could affect the mind, particularly the heart. And this connection is often mediated through the stress response. And the stress response is typically mediated through something called the HPA axis. So the hypothalamic pituitary adrenal axis. And these are gland systems that communicate by way of hormones. And really they govern these very basic functions. So our ability to fight during a confrontation or flee. And so this is an alarm system of sorts that connects the brain, the mind with the body to prepare us in terms of dealing with danger. But we're familiar with how alarm systems are supposed to work. And they're supposed to work in response to a threat. And they occur in bursts. Once the threat is absent, you turn off the alarm and you typically go on your way. When that alarm system is constantly activated, it could cause significant problems. So if you have to fight or flee from a stressor, we were talking about the heart, which is a pump that sends oxygenated blood to different parts of the body. So it helps you when you're under those circumstances for your heart rate to increase, for your blood pressure to increase, to deliver more blood to the muscles that are required for movement, right? And so if that system doesn't turn off, you have a prolonged elevated heart rate. You have a prolonged elevated blood pressure. And then physiologically, if this continues due to different stressors in the environment, it could actually cause physiologic aging. So you could have a person who might be in their 40s or 50s, but their cardiovascular function suggests that they're actually older than that due to the stressors in the environment. And so how do you combat these things? You have to really engage in lifestyle factors and modification of risk factors that really influence the lifestyle. So things like, I think one of the most effective tools you could, or practices you could implement is stop smoking. So nicotine is a vasodilator. It can, not a vasodilator, a vasoconstrictor. It constricts blood vessels, increases blood pressure. And I don't think anyone could identify a place in the body that doesn't bleed. So everywhere where blood goes, that transport of blood requires a blood vessel. So stop smoking. Stop ingesting high salt or high fatty foods. High fatty foods increase your cholesterol. High salt, wherever salt goes, water follows, and that increases your blood pressure. Also, the management of the stress response through that HPA axis that I mentioned, if you have tools or mechanisms by which you could decrease your stress, so particularly stress and anxiety increase because of uncertainty. So the importance of a schedule, the importance of carving out time to exercise, the importance of carving out time to get adequate and full and restful sleep. Also, you want to monitor, in addition to not avoiding substances like nicotine, you really want to be careful with the use of other substances, whether they be recreational drugs or alcohol. So these are really lifestyle changes that could modify your stress level and mitigate your risk of a cardiovascular event. And all these things are connected. So problems with the mind could have a negative impact on the body, and the reverse is true. So if you have heart attacks or strokes, you're at higher risk for a subsequent depressive episode. And many of these things are mediated through the stress response. And one hormone I left out in terms of the stress response is cortisol. And again, that's part of that alert system that keeps you activated, but it's meant to function in bursts. And when it does not, it could cause physiologic damage over time, and it could actually age your cells prematurely.
Excellent answer. Let me do this. I know we got a lot of questions, and Jordan, you're going to be next, but what I need to do is I need to take our halftime break to introduce two of our members have come on, our physicians have come on, and we haven't introduced them yet. And then after that, it will be Dr. Garrison, and then I have a question for Dr. Nelson Aluya, and we're going to get Dr. Court in on that one as well. First thing I'd like to do is let's introduce ourselves one more time, because I know looking at the numbers there, a lot of people came in after we introduced ourselves at the beginning. And let me do this. Let me introduce myself first because I always forget to introduce who I am. I'm Dr. Omar Bey, a pulmonary critical care and with a subspecialty in nutrition. And I'm just so pleased to have all of these physicians here to let the world know, about better health. Dr. Athley, please, can you introduce yourself?
My name is Trevor Atheley. I'm a board certified cardiologist. I'm an interventional cardiologist. I practice in Essex County and predominantly out of Newark Beth Israel Medical Center. Thank you.
All righty. Dr. Salam, please.
Dr. Kareem Salam, board certified adult and child and adolescent psychiatrist, and I practice in the city of brotherly love and sisterly affection, more commonly known as Philadelphia.
Oh, boy.
Dr. Court, please introduce.
Good afternoon, audience. My name is Dr. James Court. I practice in East Orange, New Jersey. My specialty is internal medicine, treatment of adults only.
Thank you very much. Dr. Patrick Anderson. Pat, you're still muted.
Yes, I'm Patrick Anderson. I'm a board certified gynecologic oncologist. What that means is I take care of women with cancer. I also can advise on issues surrounding fertility, obstetrics, which is pregnancy, and complex gynecologic issues. I practice with Dr. Athley, Dr. Court. I liaise with Dr. Salam, and is just honored to be part of this group. Thanks for having me.
All righty. Dr. Aluya, please.
Well, good afternoon, everybody. My name is Nelson Aluya. I'm medicine and pediatrics trained, assistant professor of medicine at Newark Beth Israel at Rutgers Medical School. Also practice out of Newark Beth Israel Medical Center. I call myself a medical advocate, and it's a pleasure to be here.
All righty. Dr. Garrison, I know you're driving, but can you tell us who you are?
Yeah, I pulled over. My name is Jordan Garrison. I'm a board certified general bariatric and vascular surgery. I practice in Hackensack, New Jersey, and Florham Park, New Jersey. Specialize in varicose veins and diseases of venous disorders.
All righty, thank you. I just want to say, as far as we physicians giving advice, please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly, give you appropriate medical advice for your problems. All right. I'd like to thank OBHealthy for allowing us to bring this platform to you and using their platform so that we can bring it. Just let you know that OBHealthy has an app which is free, and the app deals with healthy eating, weight loss, as well as health and wellness. And all you have to do when you download the app to your phone is put in 365, and the app will be free. It is a wealth of information. Please, if you have a chance, download it. All righty, so we're going to get going again. Who is next? Dr. Garrison, you were going to be next. Please proceed.
Dr. Athley, this is for you, and maybe Dr. Court can help us out as well. One of the banes of surgery is you have a patient, you're getting ready to take them to the operating room, and the anesthesiologist says, oh, you need cardiology clearance. Could you please tell us what cardiology clearance? That's question number one. Question number two is, also we have patients who come in on some types of blood thinners, especially low molecular weight heparins, and in specific things like Eliquis, and I forgot what the other one is. Eliquis and I'm blocking.
Okay.
But I'm sorry.
Xarelto.
Xarelto. So can you tell us what your recommendations are for the reversal, if need be, to reverse those medications? So those are two questions.
Can I chime in right now? Because
sure.
Jordan,
go ahead, Dr. Court.
Jordan, you took my question away because I wanted to ask Dr. Athley. I frequently see patients with an abnormal EKG suggestive of an old heart attack, and then they go crazy. You mean I had a heart attack and I didn't even know? Comment on it.
All right. Well, there are two separate questions then that I wanted to address or to accept. Number one is clearance of a patient for surgical procedures. Oftentimes, the anesthesiologist and the surgeon sometimes, they're concerned about the consequences of putting a patient under anesthesia who has evidence of significant enough heart disease that there may be some concerns about waking them up appropriately and they're not suffering severe consequences as having been given anesthesia and surgery. So I'm sometimes asked to clear the patient to identify problems that may need to be corrected before surgery, or to assure the patient's surgeon and their anesthesiologist that it's safe, go right ahead and do it. We try to characterize the risk in terms of low cardiovascular risk, except medium risk, or high risk for surgery. We use several characteristics to utilize in this evaluation. From the strictly cardiac viewpoint, we want to know if the patient's had a heart attack, if they're decompensated in terms of the heart function, that is having congestive heart failure. If they're diabetic and having insulin-dependent diabetes as opposed to control otherwise the type 2 diabetes. If they've had strokes, CVAs. These are some things that we look at. Also important from the anesthesiologist's viewpoint, maybe the question of pulmonary disease. So we put together a look at the gamut of disease processes which we think can have an adverse effect and decide whether or not the patient can be cleared. And if they can be cleared for surgery, I define the risk level, the risk of having severe consequences with the surgery. I define that in my letter to the surgeons and the anesthesiologists. Now, the question that was raised by Dr. Court is in terms of an abnormal electrocardiogram. And I must say, this also is a source of some great concern because many of these electrocardiograms are read automatically by the machines from certain algorithms. They're read by the machines, and it becomes difficult to determine and to disagree with the readings of the machines without further evaluations. So many times I see patients on consultation who have abnormal electrocardiograms. Well, my philosophy is to evaluate the patient as a whole and not just one test. So if the electrocardiogram is abnormal, I look for the kind of abnormality that it suggests, but I also talk and evaluate the patient to see whether or not the likelihood is there of the patient having had the kind of disease process that the electrocardiogram suggests. The one that is commonly mentioned is heart attacks. Did this patient have a heart attack? There are certain regions of the electrocardiogram, I don't want to become too technical here, but abnormal septal forces, previous anterior septal infarctions, etc. These are terms that I'm sure James is very, very familiar with, but there are certain parts of the heart which may be subject to misinterpretation by the electrocardiogram machine, and even by physicians, of course, because among the differential diagnoses, that is, among the various possibilities that can cause these abnormalities, are certainly serious things like heart attacks. But these are not the only causes for these abnormal electrocardiograms. So I then have to do either specific tests or other evaluations to see whether or not the underlying diseases are present, so that in order to clear patients who have abnormal electrocardiograms, I'm sometimes faced with doing echocardiograms, which can tell me about the structure of the heart, the muscle and the valves, and the function of the heart, to see if there's been damage or leakage or other things that may be happening within the heart. And I sometimes have to do stress tests. Stress tests, which I think I'd mentioned before in some detail, stress tests can identify for us the blockages of arteries to the heart and the potential for further consequences of these blockages. So I do sometimes, yes, I do have to do specific tests in order to, with some degree of assurance, clear patients for surgery, especially if they have these abnormal EKGs.
Excellent.
Oh, there was a second question, I think, that Nelson, I think, is dying to answer us about some of the anticoagulants and the methodologies, etc. Nelson, do you want to jump in on that one? The anticoagulation and how long to stop, etc. Dr. Luya?
Dr. Luya, can you hear us?
Oh, yes, sorry. I think, can you hear me?
Yes,
Yes.
we can.
Mm-hmm.
Oh, yeah, sorry. I think I called Kimmy. I missed the question.
Yeah, Dr. Athley, can you reiterate that?
The question that was raised was a general one in terms of cessation of anticoagulation or antiplatelet agents before surgical procedures. Very often we are asked to stop certain medications to allow the procedures to be performed more safely. I know that you had mentioned something about the anticoagulation, the anticoagulant, so I thought you might want to
Right.
tell us a bit about that.
Right. Usually, we see this as well. We, as primary care physicians, are usually the first physicians to ask to clear an individual for surgery. And not every patient have heart disease or, cardiovascular risk, so they may not need to see a cardiologist or see a pulmonologist before they go for surgery. So, but we tend to review the clinical status and diagnosis of the individual, and as well as the labs, make sure that the potassium, the calcium, the sodium, and everything else is functional and adequate and normal, and that the kidney function is also good. We also review the A1C, which is a measure of what the sugar looks like in the control of the diabetes. We also look at the kidney function as well. We also look at the liver function, and
we have a problem.
Lost him there.
Oh, there we are. We're back.
Sorry, I think a call just keep coming in. I'm using my phone. So, and then we check the hemoglobin level to make sure that the individual has adequate amount of blood, just in case if he's going to for surgery and there's an adequate amount of blood loss that would, be expected. But then we also sit and review the medications as well. What medications are the individual taking? Are they taking blood pressure pills? Are they taking diabetic pills? Are they taking blood thinners? Now, when it comes to blood thinners, the common saying, I think somebody had said it earlier on, who was it, Dr. Garrison, who said, you just need to lick the aspirin. A little amount of aspirin would inhibit platelets. Yeah, truly. Here in the United States, aspirin 81 milligrams, but in Britain or in Europe, it's 75 milligrams. But does that mean that 75 is less functional than 81? No, it just means that for aspirin, a baby aspirin, the small dose, would actually inhibit the platelets clotting together or coming together for about 7 days. One dose of aspirin, the entire platelet in the individual. So what we tend to do is they hold your aspirin for at least 7 days before your procedure. But if it's an emergency, of course, the individual can go for surgery, and there'll be steps to.
Another call. Well, he's busy.
Let me if Nelson is he back on? If not, I was going to answer specifically with regard to the antiplatelet agents, which he alluded to earlier. Right. We sometimes have to put patient. Or you back with us, Nelson?
Yeah. So, but
okay,
then,
you can answer, but I want to just mention a little bit more specifically about some of the circumstances associated with the use of the antiplatelet agents. But continue first. Then.
Right. So the other antiplatelets agent or anticoagulants that they tend to use, like the Plavix, or for those who are on Coumadin, again, Coumadin tends to inhibit the blood flow for about 7 days. So you tend to hold them off for 7 days before your surgery, because there's a whole cascade of elements that if the individual is on Coumadin and they go for surgery, it puts them at high risk of bleeding. And of course, the platelets inhibitors like Plavix as well is the same. Now, for those who are on Xarelto or Pradaxa or Eliquis, we tend to do the same as well. You hold them for minimum 5 days before your surgery, just to reduce the risk of bleeding. Those are the things we tend to do as well.
A quick word on the antiplatelet agents. It is very important, paramount in fact, for patients to recognize the importance of taking the antiplatelet agents without cessation for at least 1 year, unless they're so informed by the physician. They've had the very dire circumstances where we place stents. Remember, these are not normal tissue. We place stents, metallics, in the arteries of the heart. And the purpose of the antiplatelet agents is to prevent restenosis or clot formation, within these, and the highest risk occurs within the first 3 months. After 6 months, we can be relatively secure in not having to require those antiplatelet agents, the names of which I can mention some, Brilinta, Plavix, and of course aspirin. But after 1 year, we feel it is safe to not have to take 2 of the antiplatelet agents, but to settle for just 1 aspirin at that time. Well, many times, patients who've had stents are referred back to me to say, well, is it safe for me to go and do their cholecystectomy or some other surgical procedure and they've just had the stent in for a few weeks. And unfortunately, most of those instances, I have to say no. I do require, I think that the harm that can be caused by being off those antiplatelet agents and the sudden closure of an artery which was opened and stented, sudden closure can give rise to disastrous heart attacks. So I have to allow a limited period of time where it is mandated that they remain on the two agents, delay surgery as much as possible, and then at the earliest opportunity after my minimum period, then I allow the surgeons and the patient to stop the double antiplatelet agents. So very crucial.
What's your minimum period there for Dr. Athley?
Minimum period for urgent surgery, 3 months, as is being done in Europe now. Otherwise, more elective, 6 months, because stop the dual platelets for 6 weeks. We now know that 6 months is probably enough. And classically, 1 year of double antiplatelet agents, and after that 1 year, with or without surgery, we know that we do not need to continue the double approach, but a single drug, aspirin, would be enough.
Right. Yeah,
that may be changing, and we may lower those limits in the near future. Based on some of the European studies and some information that has recently come about, we may lower those limits dramatically. But right now, those are the standard recommended.
Just for the general audience, Omar, Dr. Athley and I, we've had these discussions a lot because, a lot of my patients are postmenopausal patients with coronary vascular disease who have stents, some of them recent stents. We're managing a couple of folks closely in a recent past. You don't just take what Dr. Athley says at face value that you cannot have your surgery. You should speak to that provider, whether it's an oncologist or the person who's managing your gallbladder disease. Ask them, is there non-surgical intervention that we can use, in the interim? In the case of cancer, sometimes we can choose to institute a couple of cycles of chemotherapy just to delay progression of the disease. Sometimes we can use radiation just to delay the progression of the disease. So be very clear, not because Dr. Athley says we're not right now, it means we should go home and not worry about it. There are typically alternate methods of managing the problem until such time when you can undergo surgery.
Right. I have a question for Dr. Athley.
Go ahead, Dr.
Athley, in the interim, once we stop these agents, is there any role for any other medication, Lovenox, or just prayer? Nothing would happen in terms of heart attack or stuff?
Yes. If surgery is urgently required and I'm forced into allowing the patient to have the surgery and hence stop the dual antiplatelet agents in the early phases, then yes, we can get away with using full anticoagulation. And the ones that will be short-acting, not using the tablets like warfarin and Coumadin, but short-acting, as you mentioned, Lovenox, or have the patient come in and use heparin and do the surgery after the heparin's been stopped for a few hours, rather than having to stop it for weeks or et cetera, or 10 days. So yes, if we have to, if urgent, but of course my preference always is delay if you can, and have Dr. Anderson and others tell us alternate means of treating the patient without the surgery, while giving me a chance to let my the arteries stents heal in position.
Excellent. Now, Dr. Aluya, there's a question about chest pain and understanding if it's secondary to indigestion or is it truly associated with the heart? Now, I know that as an internist, this is always a question with you because it's a question with me a lot of times. But can you tell us how you approach that, and when do you send that patient off to Dr. Athley?
Well, assessing chest pain is based on a couple of things. One, how does the individual? Is the individual 18, 14? Because I still take care of children. Is it 25? Is it 85? Now, if you look at the age, then what's the premorbid state? Is there diabetes? Is there heart disease? Is there kidney disease? Or any other issues that have been going on? And of course, you look at the medications they're taking. And not just that, before you even do that, you look at the social aspect of their life as well. Do they smoke? If they do or they don't. They're on recreational drugs as well. So all of this you put together. And of course, the functional status of the individual, and then the other medications they are taking. And before that, I'll always say that you look at the family history. Is there a family history of a particular medical condition, like heart attacks or strokes or anything like that? So all of those you put together constitute who the individual is. So a lot of time when we sit down, we ask those sometimes often mundane questions, and people are like, why are you asking me about that? Those are the reason why. We really need to understand who you are and what makes you tick and what makes you who you are. And then we begin to proceed. And then what kind of chest pain do you have? Is it in the middle? How severe is it? We look at the character of the chest pain. Is it a burning kind of chest pain? Is it a grasping and releasing kind of chest pain? Is it a pinching or itching chest pain? So all of those. And if it's just there, does it stay in one place? Does it move somewhere else? Does it move to the back, to the arm, or anywhere else? And again, like Dr. Atheley has said, we've talked about this before, females versus male. Is it a female, a young female? Is it an older female? What are the risk factors? Is it premenopausal or postmenopausal? So all of this, so that we can adequately decify what kind of chain that the individuals have. And then what brings the pain on? What makes it better? What makes it worse? All of those put together would help us come down to a diagnosis. So for instance, if you have an 18-year-old or 25-year-old who doesn't smoke, no prior medical history, no other issues, and come in with chest pain, and the pain is mid chest pain, and you say, oh, how severe is it? Oh, like I'm gonna die. All right, fine. Is it kind of a burning pain, or is it a grasping and releasing pain? If it's a burning pain, most likely that it's usually from an acid reflux. And then you ask the social, because again, social aspect is really important. It is a person having a stressful condition, or just an impactful, stressful event, maybe a bereavement, or loss of job, or something like that. That may have predisposed that individual to a stress condition that can result in heartburn. So all of these things together, because stress is as itself. Just like Dr. Salam had talked earlier on, when he mentioned cortisol, there's what they call stress-induced ulcers, otherwise called Collins ulcer. So these things are there. And if we find out which, decipher which it is, then we look for other associating issues that come with it. If the chest pain comes, are you coughing with it? If it's a cough and you're having shortness of breath, then most likely lungs. Are you having any fever, or are you having any dizziness, or feeling faint, or feeling, palpitations? Then that's most likely a heart disease, more correlating to a heart disease. So all of these put together will help us, tell what kind of a chest pain it is, and appropriately do the test. Let's say in the ER, and if it's in the office, if it's a 55-year-old female who's postmenopausal, who smoked, and have a family history of heart attacks or other issues, that individual will warrant an EKG. So we'll see what's going on. And if we see abdominal EKG, we're listening, and the blood pressure is really high as well, then that individual will have to send to the ER immediately. But if it's not an emergency and we think we can handle it, we can give them some, reduce the blood pressure, put them on aspirin to help protect, or even give them some medications that help keep the vessels open a little bit if it's angina, and then we refer to Dr. Atheley to get on to do further tests. But have an extra eye on that individual. So that's how we proceed when we do those things.
Yeah. So Omar, I know my day is gonna come. So while we have Dr. Athley on the hot chair, I'm gonna get him for all I know he knows.
All right, we'll get you back.
So up to this point, we've talked about issues that affect the heart muscles as it pertains to perfusion, blood flow. Dr. Athley, two areas I'd like you to touch on. One, that continues to affect the muscle, and that's the concept of deposits within the muscle, certain conditions such as myeloma, how things that are autoimmune such as lupus can affect the heart muscle. And then after that, if you could just touch on valvular disorders that affect the heart and the functioning of the heart.
Right. I would perhaps require a few hours to go over those in detail with you. But anyway, just a very quick mention that anatomically, we look at the various portions of the heart and the various diseases that can affect those portions. The outer area is called the pericardium. It's a sac in which the heart sits. It has a small amount of fluid there, and there are disease processes which specifically affect the pericardium. Then inside that is the bulk of the heart, the muscle. There are myopathies and other diseases which affect the heart muscle, including damage to the heart muscle with heart attacks. The heart muscle may become weakened from a variety of circumstances. One of those is a deposition of other tissues. A starchy tissue called amyloid, for example, may be deposited in the muscle and cause significant malfunction of the heart, amyloidosis of the heart. Sarcoid may be deposited in the muscle and some of the conduction tissue, and that may also affect multiple other aspects. You can see it manifest in Dr. Omar Bey's area, especially in the lungs, etc. So sarcoidosis may have widespread effects. So there are many diseases which may be deposited into the muscle. The endocardium, or the inner layer of the heart muscle, includes the valves. And here's where we could then talk about valve disease and what affects valves. Well, we used to see a lot more rheumatic heart disease and valvular disease as a consequence in the old days. And yesterday, as a matter of fact, I was privileged to have someone who came from Kenya to see me, who had rheumatic fever as a child. She was governor of, I'm not going to tell you all the details, but anyway. But rheumatic heart disease was one that was well known to affect the valves of the heart, and there are other diseases that can affect the valves. One can get infections called endocarditis involving the valves. So what I would like to say is that the heart as a whole, yes, but individual components or parts of the heart may be specifically subject to certain diseases. I know that time is running short, and I did not want to, is Dr. Salam is still here. Maybe privileged to ask him, make a comment and then ask him a question. Omar?
Yeah.
Good.
I'm sorry.
I wanted to make a point, because there was a point made earlier, and I don't know if it was made partially in jest, but it's a real entity. There's a question of broken heart syndrome was mentioned. Mm-hmm. And I certainly want Dr. Salam's input in terms of the causation of that. But what we have discovered over the past maybe a decade or two now is a disease entity called broken heart syndrome. And it is not necessarily the broken heart from affairs of the heart, etc., but it may be any subject, any patient subjected to severe stress, severe stressful situations. And we found many patients who present with a specific kind of damage to the heart muscle that mimics a heart attack. So these patients predominantly come through the emergency room with the signs and symptoms of a heart attack. And we recognize the real truth when we do cardiac catheterizations or other specialized tests on these patients. The other day, I had to catheterize a 35-year-old young patient who came in with what we thought was a heart attack, looked like a heart attack, behaved like a heart attack, but indeed it was not a heart attack. The arteries to the heart were perfectly clean, and the area of the heart that was damaged was quite characteristic. It was the tip of the heart, what we call the apex tip, which rather than being slightly pointed, and it was spade-shaped. And in fact, that's why we now use the term Takotsubo's disease, because it looks like the old Japanese fishing pots, the Takotsubo's. But in any case, that is a real entity that we're seeing more and more now, stress-induced cardiomyopathy, Takotsubo's disease, caused by major stress, but we don't know the mechanism. We theorized several different mechanisms. We don't know the mechanism. Dr. Salam, could you help us at all with this? Also, the importance of whether or not there's some counseling that we can give to these patients so it doesn't recur, because the consequences may be much worse the second time. Most of these patients recover quite well after a few weeks or months of having had the broken heart syndrome.
You know, I have to be honest. I don't see many of these cases, and in my day job, I see largely adolescents who, you know, their cardiac function tends to be fine unless they have a congenital cardiac abnormality that's discovered on an EKG that I perform prior to starting them on a stimulant medication like Ritalin or Adderall, or an atypical antipsychotic that's used to stabilize mood and could affect the cardiac conduction system. So I'm not seeing many of these patients, but again, as I alluded to earlier, there is no artificial divide between the mind and the body, and stress could have impacts on the heart. It could affect the cardiovascular system. It could cause tachycardia. It could cause constriction of the blood vessels, leading to hypertension. But this is not something that I commonly encounter in my practice.
Right. So if I may, if I may add to that, and I was going to talk about that.
Yeah.
And we did mention this maybe a couple of I'll use the word episodes now, since we have so many videos on YouTube where we talked about Takotsubo. You know, first described a few while ago. I think probably about 10 years now, really, and we're describing it. You know, like Dr. Atheley had said, the Japanese fishing port. That's just the way it looked. It looked like the lower end is a little ballooned out, and that's the term. So and just like Dr. Sanama said, we as individuals were human beings. And we know we are constituted with spirit. You know, we have a soul and a body, but out of all that spirit, body, and soul, there are whole other components that affect who we are and determine what we eventually turn out to be. And like you said, there's no spirit, there's no boundary between either one of these components. We also tend to forget that not just the physiological aspect and the mechanical aspect of human beings, there's also the magnetic component of human beings, where the magnetic rings around the earth affects how we as an individual also operate. For instance, it's going to rain tomorrow. Grandma knows it's going to rain tomorrow. Most people who are listening know when it's going to rain tomorrow. How do they know? It's the magnetic changes as the earth and the climate moves as well. So all of this comes down to who we are. Now, coming down to Takotsubo, yes, grandma was always right. People did have a broken heart from severe emotional stress. And all of that put together. And that's why I was going to add a little bit to that before I go into the Takotsubo itself. When people pray, especially when they have a collective prayer, and I learned that something recently, and it was not in church, but outside of church, where, you know, like the Bible said, when, you know, do not forsake the fellowship of the brethren, meaning you come together and pray together, you know, you have a bigger effect. In other astrological aspect of life, we begin to realize that, yes, these things are true. When a couple of people who come together believe in something and project astrally or spiritually an effect, all of those things have a compounding effect that also help the magnetic, the physiological, and also the humoral neuroendocrine component of an individual. And this, you know, I don't want to go too technical, but all of this determine who we are and how our body responds to stress, to joy, to pain. And one of the hormones that people tend to forget again is oxytocin. Big in how the brain, you know, alter all of this is. But the base of everything is inflammation. Now, we begin to know when we talk again, and people have heard us say this over and over again here on when we talk about epigenetics, the food you eat, the environment you live, the altitude, and everything the people who you hang around with, how does it affect your health? All of this put together really does affect your health. Now, coming down to Takotsubo, there's the humoral neuroendocrine component of this. Now, does that mean that everybody who have severe emotional distress tend to have broken heart? No, not everybody. But have we identified those individuals who will? Not yet. We will eventually identify. But what we begin to know now is that there are acetylations of genes that predispose individuals to inflammatory components. One of the ones we know now, and one of the things I think Dr. Anderson may get to see this down the road, is that individuals, especially Black women, and I've seen that, who have osteonecrosis of the hip, but they don't have sickle cell. We begin to wonder, a lot of people have not even thought about that, but we begin to realize that the inflammatory process, what they call AFG, the mitotic, the androgen mitotic proteins, there's 2 to 6. And when those things are upregulated, increase the risk of inflammation in individual. So all of this is what the future of medicine is looking at. And that's why it's important that we begin to pay attention to what the future of medicine looks like. So down the road, yes, there are individuals who are prone to having broken heart syndromes. I'm sure the genetic components to it, but at this time, we don't know that. But yet, it's true, it's an entity, and there are neurochemical transport changes that take place that help, that create that anterior or the lateral out portion of the heart to balloon out that presents like heart attack. So yes, how do we prevent that? Resilience.
Yeah.
Resilience.
All right.
And being black.
I have
one thing.
I have a quick comment.
You know, all right. So Dr. Salam, we're going to get you a quick comment, but I do want to cover this here before we close, because we're coming down to the close to the end of the show. COVID in the heart. Dr. Athley, Dr. Salam is going to chime in, and then I would like for you to cover that, especially with COVID rising throughout the world, and especially in areas of, you know, like the Caribbean islands, it's rising, in areas of Africa, it's rising. So if we can, and especially the United States as well, especially for Black and brown people. So I want to cover that. Dr. Salam?
Right, before you go on, when they're done, I want to talk about diabetes on the heart and how it begins to really affect us, especially when it comes to the valves.
Okay.
We need to talk about that.
All righty, good.
In terms of a psychological manifestation of a problem through chest pain or cardiac issues, that's really a diagnosis of exclusion. So you want to rule out the medical possibilities of a heart problem before you arrive at the psychological underpinnings of a heart problem, because it's those medical issues that could do you the most harm the most quickly. So you actually want to make sure someone's not having a heart attack before you move on to, you know, something like broken heart syndrome or a psychological issue that could be contributing to their cardiac chest pain.
Mm-hmm.
Loosely put it, it's just not in your head, right?
There you go. You know, this is such an interesting topic. Dr. Athley, I wanted to ask you, has anyone said that it might be associated with just cardiac spasm as opposed to the clotting of the cardiac arteries?
Yes, that certainly is one of the theories. I said there are a multiplicity of theories. One of them is, of course, a neuroendocrine, a sudden discharge of a large amount of catecholamines, the adrenaline type hormones, which can suddenly cause an increased work of the heart and may affect the arteries and the blood supply itself. That may happen. And then by the time we diagnose these people at cardiac catheterization, it's reversed. So we no longer see any effect on the arteries themselves, but we just see the damage to focal areas, certain portions of the muscle. That's a possibility. Coronary artery spasm is another consideration. Again, some of that may occur transiently, and there are a variety of circumstances in which coronary artery spasm may occur. Not as clearly related to stressful situations. It most commonly occurs in the early hours of the morning during what we call REM sleep, rapid eye movement sleep, as the most common time that we see true coronary artery spasm in what was called the Prinzmetal's syndrome, a special kind of angina pectoris. But spasm has not been proven. We've not been able to document that spasm occurs more frequently in patients who have the broken heart syndrome, but is one of the theories, one of the possibilities, because of course, if spasm occurs and then it's totally reversed, when you look at the coronary arteries, they may look normal unless you bring out certain specific tests to try to evoke spasm. So that's a consideration. But as I said, there are many considerations, and Nelson has brought an interesting dimension to look at in that regard, but proof is far from there. The one thing we can say, however, is that unlike heart attacks, the prognosis for full recovery after the broken heart syndrome is very good, that many of these patients recover fully without significant lasting damage to the heart muscle.
Yeah, there was a question, Dr. Athley. There was a question, Dr. Athley, was after a heart attack, can you recover? And also, once you have coronary artery disease, can you recover from that, without serious surgery or serious, stents and stuff like that? Yes. I just wanted to get those questions in real quick because they
I'll answer those briefly. I'm just looking quickly at the time, because I know you did ask me about COVID. After a heart attack, as opposed to after angina pectoris or ischemic heart disease, a heart attack actually does leave some damage. So the question may be the amount of damage, the kind of damage, and the location of the damage. It is quite possible for patients to compensate in their function and to do quite well after heart attacks. I know that there are always questions that I get in the office as to after heart attack, will my husband ever return to fully normal life? What can we expect for the future, etc.? Unfortunately, in the broadest sense, the occurrence of a heart attack does constitute a process which diminishes the total longevity of the patient. The patients who've had heart attacks, so you take the average 65 to 69-year-old who's had a heart attack, then there are some studies which show that the longevity may be diminished by 5 years in males and up to 10 years in females. That is, diminution from what might have been the predicted lifespan for one at that age who did not have a heart attack. So yes, the presence of heart attacks in general, the presence of heart attacks will in fact confer limitations in terms of one's longevity, because of course they're prone to have further heart attacks. If you have one heart attack, that's the biggest risk factor for having a second heart attack. So these are always things to consider. But in truth and in fact, if you take patients as individuals rather than statistics, take patients as individuals and define the extent of their damage from the heart attack, their degree of recovery, and get them to observe what hopefully may be easily treatable or reversible underlying predisposing factors. For example, a heavy cigarette smoker who had a potential of having twice the potential for heart attacks as the normal population. If he stops smoking and does that along with control of other risk factors, within 1 year, his chance of having another heart attack are diminished by 50%. 50%. And after 10 years, even if you've had a heart attack, after 10 years of cessation of smoking, it's as though you never smoked at all. No further consequences from that in terms of the heart disease. So yes, control of risk factors, control of whatever you can control easily or properly after the heart damage has occurred may restore you to adequate function, but unfortunately, many of us are unable to do that appropriately, and we still are faced with the overall statistic that there will be a shortening of one's expected lifespan after having had a heart attack. COVID and the heart, I'm not sure how much we can talk about, but in terms of COVID and the heart, I like to look at COVID and the heart in terms of the immediate problems that may present at the time the patient has COVID. And the question, I see there was a question here about a patient who had COVID, what might happen after they had COVID? Well, in the setting of the acute episode, COVID can affect, again, as we look at the layers of the heart, one can get the pericardium affected with inflammation and fluid, pericarditis, pericardial fluid, during the process of the COVID. And importantly, one may get the muscle affected. The heart muscle may be affected with what's called a cardiomyopathy, myocarditis, inflammation involving the muscle so that it does not function adequately as a pump. No blockage of the arteries in that particular instance, but merely the heart muscle being damaged, infiltrated by the coronavirus itself. So that can happen. And of course, because we now look at COVID as a vascular disease in a large measure, where the COVID causes inflammation of the blood vessels, if the COVID causes inflammation of the blood vessels of the heart, yes, it may cause a kind of heart attack. So there are many ways in which COVID may affect one acutely, but the big concern that we have is people who did not have heart damage during the actual episode of COVID, but who later present with chest pains and other problems afterwards. Is it because of the heart or not? And that's a vexing question. And we're forced into doing some very sophisticated studies on patients who have had COVID and didn't have COVID heart disease documented at the time of the active COVID, but come later on with chest pains, persistent pains, changes. These are some of the symptoms we see. Recurrent pains, we see changes in the heart rate. Patients may have fast heart rates or slow heart rates. Patients who may have changes in their blood pressure control, high, low, etc. Are these related to COVID? Is that the effect of COVID on the heart? Is that the effect of COVID on the blood vessels? We're still not sure. But one test that I've had to do is MRI of the heart. I've done that on several patients, but without, I must say, in my own practice, finding much by way of permanent damage in these patients. There are reports, however, there are reports, especially one that came over from Germany last year, of a high percentage of patients who had COVID disease and were hospitalized, who even after recovery from the COVID, had documented evidence of inflammation and problems occurring in the muscle, which could only be defined on some of these very sophisticated tests, the MRI being one of them. So in answer, I can say, to make it brief, yes, I do see many patients who have chest pain or shortness of breath after having had COVID. But no, I'm not able to document or demonstrate that it truly is, there's an objective finding that the COVID has left damage that I can prove on such patients.
Excellent, excellent. Dr.
COVID
Aluya.
COVID is right. Right.
ahead.
COVID is right.
I'm sorry.
COVID is writing his own textbook. As we go, we're going to learn a whole lot more.
That's true.
From the heart to the brain to the heart to the kidneys and everything else. We've seen that all through. We'll get to learn. But the beauty of it all is it has advanced medicine to a point where technology and science and AI and everything is infused into it, and we're going to learn more. But since we're still on heart recovery and longevity, one of the other questions they tend to always ask is, Doc, when do I resume sexual activity after a heart attack? And Dr. Athley, I'm sure, before I go into my spiel with diabetes and valvular heart disease, Dr. Athley, what do you think?
Good question. Of course, the answer depends very much on the individual and what their level of activity was before, the age, etc. So one has to be very individualistic in recommending. But in a broad general sense, the heart does see sexual activity as an exercise. It's reflected in increasing in heart rate, increasing in blood pressure, etc. So we have to be concerned that the patient is capable of having an increase in the heart rate and the blood pressure and doing a bit of work. So given those circumstances, we would tend to delay for a few weeks after heart attacks or open heart surgery before allowing patients to resume fully. One of the tests that we have done, although that may vary so much in terms of individuals, it's hard to give a recommendation. But one of the tests that we have done is mention to patients that if you can walk quickly up 2 flights of stairs, that is considered by some to be the equivalent of sexual activity. Well, that's very to individuals.
Is that walking or running now?
But I try very much to individualize the patient and talk to them and advise them that so that they can resume their normal activities, sexual activity and other activities, as early as they can. I don't want to limit their life and limit their enjoyment of life. No, I want to let them live their lives.
Excellent, excellent. Well, unfortunately, we've come to our time has just run out. And, if this was such an enjoyment, Dr. Athley, thank you very much.
Dr. Bay, if you don't mind, 1 minute. We'll talk about
1 minute. Go ahead, Dr. Aluya. For you, I want to do this. Go ahead.
I'm going to ask for a minute too.
Okay, well, let's all jump in. Go ahead. Nelson, you start off.
So there's what they call the pandemic before the pandemic. And the pandemic before the pandemic is actually diabetes. And we begin to see the flow of what it is. And it's going massively across the world right now. And what's up, especially for those of people of color and those in developing countries who are now beginning to, as they move into middle class or adopt Western style living, diabetes become an issue. Now, when you talk about the heart, especially, we talked about the valvular heart disease. Dr. Athley has said earlier on that we used to see valvular heart diseases here, but we no longer see valvular heart disease. Why? Because vaccines has helped. They've helped prevent, a whole lot of those infections. And as we, live in a modernized, system where we have access to water, access to a whole lot of stuff. So all of those valvular heart disease tend to reduce, but replacing it is valvular heart disease from one, hypertension and diabetes. Now, unlike the valvular heart disease, the defect in the heart from a valvular heart disease from infection back in the days was in the annulus, meaning at the base of the heart. So when you refix it, you can fix it with, what they call the TAVR, transcutaneous valvular repair. So you put a device to keep the valves open, to work. But what we begin to see with diabetes, it doesn't affect the base, it affects the leaflets. And that's why it's so important that we, an individual, and those listening, please, if you go see your doctor, ask what your A1C is. Everybody should know their A1C status. Control your sugar. Because if it does, it affects everything from the brain to the foot. So, but since we're in the topic of the heart, it affects the valves. In 20 to 35% of the cases, it really does. And this is what the studies have shown. So that it's really very difficult, especially for those of people of color, when they tend to have valvular heart disease from the damaging effect of diabetes. It's hard to fix the valves using those devices. So these are some of the things that we need to talk about. And, I just wanted to bring that up there so we understand. So control your sugar, control your blood pressure.
All righty. Dr. Anderson.
My 1 minute, I was just responding to one of our questions to if we could extend the topic of heart disease into our November webinar, because there's just so many aspects to this. One aspect we should talk about is how menopause in women affect their cardiovascular function, and how pregnancy affect cardiovascular function. And a time when we talk about increase in morbidity and outcome in neonatal outcome and pregnancy in women of color, I think this is also a topic which we should start to look into it, because a lot of it relates to the effect of pregnancy on the cardiovascular system.
Okay, so something we can do for November then, and just an idea, just so we're talking about it here at the, while we're still live, but maybe from all specialties, we can see how our specialty relates to cardiology. I know from pulmonary, I feel the heart and the lungs work so closely together that there's nothing that I do each day that I don't think, is this a cardiac problem or a pulmonary problem? So there is a lot that we can talk about that we have not covered today, that maybe in November we can bring some of that to light. And I'm going to make a challenge for each physician to kind of think about what we can talk about from your specialty related to cardiology. And I think it will pull everything in. If you don't mind, and if the audience don't mind us covering, having cardiology part 2 for November. So I hopefully that will be fine. Thank you, Dr. Anderson. And if the physicians are willing to do that, we're going to rock and roll. All righty. Thank you for this most interesting webinar. The first thing I'd like to do is thank OBHealthy for allowing us to bring this to the world. I think this is so important for Black and brown people, especially in the time of COVID. You have to make sure that you are healthy, your immune system is up, so that we can survive as a people, we can survive this virus. Number one, understand that we are every second Saturday at 1 o'clock Eastern time. Please tell others so they can join. And the most important thing that I can say before we end is please do not change any aspect of your medical care before you consult your physician. Only your physician can truly take care of you the way you need to be taken care of. Again, thank you, brothers, for coming on with me. And we will be here next month, same time, same station. Thank you very much. Take care, everyone.
Okay.